Okay, last week we started with Autonomics. This week we're going to do the bread and butter of it all. I gave you a little intro last week. If you want to turn to page 113. 113. Of course, to back up a little bit from towards last week, we said we're going to go through the autonomic drugs, of which there are literally hundreds. And the easy way to do this, or easier way to do it, is to learn the mechanisms and then what the receptors do. We went through the table last time, we're going to do it again today. But these 10 mechanisms that are on page 113 to 14 are all the ways that you can manipulate the autonomic nervous system with drugs to hopefully produce a patient benefit. And that's what I'm going to do today, and we're going to learn all these 10 things. Now, I number them 1 to 10. This isn't official. It's just me putting a number on them, all right? So if you're not looking in a book for mechanism number 3, you're not going to find it. I made that up. I just got to put a number on it and get a step somewhere, right? So these are my numbers. They're not real numbers. Real mechanisms.
On this one to really take the serum tryptase levels, like if this is you suspected that there's
Other
this level got back, and then you got the number.
Can you guys check and see if your microphone is muted? Thanks. So anyways, I want to go through these mechanisms because they're simple once you kind of look at them. And so let's do that, and that's a way to nicely review from last week and to get to the gory details. So now in this, you gotta turn it on, it'll work better. All right, this is page 115. Page 115. Now this is a series of drawings from a British pharmacology book. I like the way they did them, so I use them. So what they're trying to show here is an autonomic neuron. See my little cursor. And the autonomic neuron is attaching to a tissue, a postsynaptic receptor. And the way they draw these is, let's go through. This is, first of all, normal state. In other words, this is just the physiology of a sympathetic nerve. So they're showing that a nerve impulse triggers norepinephrine release. The Brits use NA because they call it noradrenaline, but it's norepinephrine in the United States. So you have an action potential, comes down the nerve, and it causes the activation of the vesicles. That's the little packet, see the pink thing? With norepinephrine in it. And when an action potential comes down a sympathetic nerve, it causes the norepinephrine to be released into the synapse. Then the norepinephrine, first this arrow straight forward, attaches to a postsynaptic receptor and you get a response. The receptor is either an alpha, beta, or dopamine receptor. Some of the norepinephrine feeds back onto the presynaptic receptor. And as I mentioned last time, they're always number 2. So whatever the receptor is, there'll be a number 2 receptor. This is alpha 2 here they're showing. Presynaptic to be negative feedback control. And then norepinephrine eventually, they're showing some of it just diffuses out of the synapse and it gets metabolized by COMT. We said there's 2 metabolic enzymes for catecholamines, COMT and MAO. So COMT metabolizes the norepinephrine that dissipates or gets out of the synapse. However, the big thick arrow, see this one going back into the nerve? The big thick arrow shows that norepinephrine is taken back up into the nerve. We call it reuptake. Taken back up into the nerve in a two-step process. It's very important. So, we're showing you here. There's norepinephrine released, does its thing, you get alpha stimulation, then it gets taken back up into the nerve. And the first place it goes, of course, is into the axoplasm, or the cytoplasm of the nerve. We're showing that here. Cytoplasmic norepinephrine. Now, a second process takes it from the nerve back into the vesicle, into the package. And that requires energy, and that's where they're showing this mitochondria here with MAO in it. So this says MAO here. So it looks like a pill. That's supposed to be a mitochondria containing MAO. Because when norepinephrine is taken back into the nerve, it's against its concentration gradient. There's a lot of norepinephrine in the end of the nerve. There's less in the synapse. You got to take it from the synapse back into the nerve. You're pushing it up against the concentration gradient, and that takes energy. And actually, there's a transporter. It's called a catecholamine transporter that carries it energy-wise back into the nerve. Now, once it's in the nerve cytoplasm, if you just leave it there, then it's susceptible, or it's right next to MAO. And if it just sits in this cytoplasm, the MAO is going to break it down and it's going to go away. So you have to do the second thing, and that's it. Put it back in the package. Put it back in the vesicle here. These little round things. So they're showing two of them. Because once it's in there, it's protected from being metabolized by monoamine oxidase. So the metabolic enzymes required to break down the norepinephrine are sitting right there next to the norepinephrine. The reason they're not breaking it down is because it's protected in these vesicles. That's a two-step reuptake process for catecholamine reuptake. So that's it. Let's look at it again. Action potential comes down the nerve, causes the fusion of the vesicle to the end plate here, releases norepinephrine. Norepinephrine stimulates the receptor, feeds back in the nerve to not release anymore, and eventually gets taken back up into the nerve, and then from inside the nerve into the package to protect it from MAO. Right, does everybody see me with me on this? All right, so let's look at mechanism number one, page 113, interfering with the synthesis of the transmitter. That's mechanism number one. And if you look on page 116, I put mechanism number one. Again, I'm just making those numbers. So let's look at this. This is interfering with the synthesis of the catecholamines. So, how are catecholamines synthesized? Let's look. There's tyrosine in the blood, amino acid. You get it from your food, you eat it. And tyrosine is taken up into the nerve, acted upon by the enzyme tyrosine hydroxylase, which is the rate-limiting enzyme. And then it formulates DOPA, D-O-P-A, and DOPA is acted upon by another enzyme, dopamine carboxylase, and forms dopamine. Now, if this is a neuron that contains dopamine, that's the end of it, then dopamine goes into the vesicle, sits there, there you go. But however, most of the nerves then further convert dopamine into norepinephrine. And norepinephrine is stored in the vesicle. They've blown it up here, showing you that dopamine is taken up into the vesicle, and the enzyme dopamine beta hydroxylase is in there and changes it to norepinephrine. Now, if this is the adrenal medulla, it'll be further changed from norepinephrine into epinephrine. That's the last conversion. But by far the vast majority of adrenergic nerves contain norepinephrine. Small amount in the brain, small amount in the periphery contain dopamine. And we mentioned last week, primarily in the renal artery and the GI system. And then some contain epinephrine, that's mostly in the adrenal gland. Okay? So, what happens if you block the enzyme tyrosine hydroxylase and you don't let norepinephrine be synthesized? Well, eventually these neurons are going to be depleted of catecholamines. You're releasing, you're supposed to take back up, you're not making any new stuff, so you're going to run out. So is that mechanism for a drug going to be sympathomimetic or sympatholytic? It's going to be lytic, right? Because you're going to run out of norepinephrine, so it's going to be a sympatholytic effect, and you're going to get a sympatholytic action, which we'll go over. Okay, everybody with me on that? That's mechanism number one. Number two, metabolic transformation by a different pathway. Look at page 117. Next page. Now, in pharmacology, this is called the false transmitter mechanism. What you're doing is you're giving the body a false thing to synthesize. It thinks it's I'll get my mouth work. It thinks it's synthesizing. That's a mouthful. Norepinephrine. However, you didn't give it tyrosine to convert. You gave it a false transmitter. So it synthesizes the wrong transmitter. You fooled it. So it's storing in its vesicles not norepinephrine, but a false transmitter. So when you release catecholamines, you don't get the effect you'd expect because you don't have the transmitter sitting in the vesicles anymore. So let's take a look. Here's the starting product, and instead of tyrosine, you give, this is called alpha-methyl-dopa. And so alpha-methyl-dopa is taken up into the nerve, and you synthesize alpha-methyl-dopamine, and then you synthesize alpha-methyl-norepinephrine. It's in white inside the package, see? So there's some norepinephrine in there, but then there's a lot of false transmitter, or alpha-methyl-norepinephrine. Wrong one. Then when you release it, you release alpha-methyl-norepinephrine, and you got sympathomimetic or sympatholytic effect. What do you think? So it's not the right catecholamine you're releasing. Is it going to be mimetic or lytic? Lytic, right. There was an antihypertensive drug that's it's still around, nobody gives it. It was used for many years, Autonomic it's called, alpha-methyl-dopa. And you used to give it for hypertension because then the person would develop the wrong transmitter and their blood pressure would go down. But it had a lot of side effects and it was a lot of the drug. But that's mechanism number two. Okay, mechanism number three. Blockade of transport system at the nerve terminal membrane. So let's look at that. If you're blocking norepinephrine, so here we go. This is our normal action potential coming down. There's norepinephrine, it gets released, it attaches to the receptor, it signals the autoreceptor to slow down, release. Now, to get the norepinephrine to go away, you have to take it back up into the nerve. What happens if you block reuptake? You don't allow norepinephrine to be taken back up into the nerve. So it stays in the synapse in a higher concentration for a longer period of time. And so do you get a sympathomimetic or a sympatholytic effect? Mimetic, right? Because you got excess catecholamines. And the drugs, look at this. Cocaine is the famous one that blocks reuptake of norepinephrine. And you give somebody cocaine and they get high, they get an analeptic effect because of all the catecholamine and dopamine released in the brain. You're blocking reuptake. Imipramine and amitriptyline are tricyclic antidepressants. We'll talk about it. They also do that. We'll talk about it later. So that's blocking reuptake. That's sympathomimetic. And a drug like cocaine then is going to produce sympathomimetic effects. And you'll be more awake, and your blood pressure will go up, and your heart rate goes up, and all the sympathetic things. All right, everybody with me? Let's go to number 4. Block the transport system in the storage vessel. The next page. That's page 119, mechanism number 4. And that's what they're saying is you're blocking the catecholamine from being stored in the package. Basically is what it is. So let's take a look. Action potential comes down. There's norepinephrine in this nice little package. It gets released, and then it's supposed to be taken back up again. But what happens is you give a drug that's called reserpine, which was used for many years as an antihypertensive. And what reserpine did was cause norepinephrine to be displaced out of its vessel. So the norepinephrine now is just sitting in this cytoplasm of the nerve. And as they're showing with this little arrow, it's open or susceptible to MAO, so the MAO metabolizes it. It's gone. So if you displace the norepinephrine from its little package, don't allow it to be stored, then it's going to be metabolized and eliminated, and you're going to have a lot less norepinephrine in that neuron than you're supposed to, because you blocked the storage of it in the vesicle. So is that sympatholytic or sympathomimetic? It's patholytic, right? Because you got less catecholamines. And reserpine is a pretty good antihypertensive, but people committed suicide because they had so much depletion of catecholamines. They got seriously psychiatric depressed, and they had a lot of psychiatric side effects for that, was behavioral side effects, because you got rid of all the catecholamines in their brain, and that was not a good thing to do. They had a great blood pressure, and then it killed themselves. So that's blocking storage. All right?
Do these also cause sedation as well?
Yes.
Or why don't they then, if that's the case?
Yes, it would. Reserpine causes sedation. That's one of the main side effects. Because catecholamines are so depleted. All right, number 5. Causing the release of the transcon. So go to the next page. Mechanism number 5. And this, they're calling them indirect acting drugs. We already talked about these. Oh, this is so exciting. Let's go through it again. This is storing norepinephrine, all the packages, and what if a drug comes along and just causes norepinephrine to be released? That's what they're showing. So norepi gets released, does its thing. Taken back up into the nerve, some diffuses away, etc. So basically, this is a drug that causes norepinephrine release. Let's say in a couple words. Is that going to be sympathomimetic or sympatholytic? Sympathomimetic, right? You're causing catecholamine release. And look at the drugs. Amphetamines are 100% indirect acting. Indirect acting is saying the word. This is a loaded word in pharmacology. When you say indirect acting, you mean the drug is not going down here and attaching to the receptor and producing the effect. The drug is working indirectly by causing catecholamine release. So that's amphetamines. Amphetamines are 100% indirect acting. You take methamphetamine or any of the amphetamine drugs, they cause catecholamine release, and that's what produces the effect. The drugs never hit a receptor on a ephedrine is another one, remember that? And ephedrine has a very prominent indirect action. If somebody's catecholamine depleted, then ephedrine doesn't work as well because that's one of the mechanisms. We're going to learn them all. I'm going to teach you a little sentence to say on what ephedrine does. Part of its action is indirect acting. What drug from last semester has indirect action? Anybody remember? Indirect acting sympathomimetic drug. I'm testing your brain this early in the morning. Ketamine.
Ketamine.
Yeah, ketamine works. Why is ketamine bronchodilate? Why does ketamine maintain blood pressure and heart rate? Because it causes catecholamine release. It works indirectly. Ketamine doesn't attach to the receptor and stimulate alpha or beta or whatever, but it causes catecholamines to be released. So two of our drugs that we use quite often, ketamine and ephedrine, both have indirect action. Other drugs too, but I mean as far as our drugs that we give quite often. So everybody can see that indirect action, right? Okay. Next one. Number 6. Preventing the release of the transmitter. So that's on page 121. Next page. What if you prevent the release? The indirect actings were causing the release. All right? This the next category is what if you prevent the release? So what they're showing here is you're blocking norepinephrine being released. Is that going to be sympathomimetic or sympatholytic? Sympatholytic, right? If you can't release catecholamines, you're not going to have a sympathetic response. Now, Bertilium is not on the market anymore. We used to use it for refractory V-fib in crash carts, for cardiac arrest. The ones that still are prominent use are clonidine and dexmedetomidine, are two alpha-2 agonists. So if you stimulate this alpha-2, look at the clonidine here. Watch the arrow. The arrow goes right here. You're stimulating a presynaptic alpha-2 receptor. That's activating the negative feedback system, and you're causing a decrease in catecholamine release, blocking release. That's what dexmedetomidine does, Precedex. That's what clonidine does. That's why it's antihypertensive. All right? Everybody buy that? All right, number 7. Well, what if you're just an agonist? That is an easy one. So the next page, 122. These are direct-acting drugs. They just go to the receptor and stimulate it. Nothing fancy about that. So norepinephrine, which is Levophed, phenylephrine, which is neosynephrine. They're giving isoproterenol, which is Isoprel. We don't really use anymore to any great extent. All these drugs, you see the little arrows, where do they do? Oop. The arrows go right to the receptors and stimulate it. You don't even need the neuron there. So they're direct alpha, or direct beta, or direct both, or whatever. So that's easy. Just an agonist at the receptor. Okay, the next one. Mechanism number 8. There's only 10, so I'm almost there. Mechanism number 8. This is a classic antagonist, just a blocker. Alpha blocker, beta blocker, dopamine blocker, whatever. Right? So what they're showing here is phentolamine or regitine, it's an alpha blocker. Propranolol or Inderol, which is a beta blocker. Prazosin, which is an alpha blocker as well. Minipress. And these drugs just go directly to the receptor and block it. So nothing can stimulate it. You give it alpha blockers, beta blockers all your career. Surprisingly, that's sympatholytic. to block the receptor, and that's pretty straightforward stuff. Okay. Go to the next page, 114. Number 9, inhibiting the enzymatic breakdown of the transmitter. All right, so which one is that going to be? I'll find it. Yeah. So mechanism number 9. What if you mess with the enzyme that breaks down the catecholamine, or the whatever? In this case, I switched to the parasympathetic side to give you an example, because this is a drug you give all the time. So I thought, well, I'll use the drug you're used to. So this is the parasympathetic side, and of course acetylcholine is the transmitter, parasympathetic nerves. And what they're showing is acetylcholine is packaged, released, attaches to a muscarinic receptor, cholinergic receptor, produces its effect. Well, what if you give a drug that messes with the cholinesterase? When the acetylcholine is released here, it's metabolized in the synapse by cholinesterase. What if you give an anticholinesterase, neostigmine? Do it all the time. What happens? Well, the acetylcholine can't be broken down, so the concentration of it rises in the synapse. When the concentration exceeds the amount of relaxant that's there, you reestablish normal function, or reverse the relaxant, what we say clinically. On the sympathetic side, you can do the same thing by giving an MAO inhibitor. If you inhibit the enzyme MAO, you can't break down the catecholamines, so you get more of them. What are the MAO inhibitors used for? Yeah, they're antidepressants, right? They make you feel better, because you raise catecholamine levels in the brain. There are COMT inhibitors too. You inhibit the enzyme COMT, it also inhibits catecholamine breakdown, and you get a sympathomagnetic response. Okay, so that's pretty easy. I think it's easy. Okay, finally, number 10, and I got a different picture in the book than I do on my little slide here. I don't think I have this. Number 10, I added to this. Remember I said that Drs. Goodman and Gilman in their book do the table and they do 1 through 9. That's the 9 mechanisms, and I'm adding a number 10. This is me. And the number 10 mechanism that I added is interfering with the second messenger system inside the nerve. The drug example for this is milrinone. Can I guess you've all given milrinone as an inotropic drug? Somebody's mic isn't muted. Can you check? So anyways, let's go through that. And what I mean by the second messenger is this. Look on my slide on the screen. All right, there's just trying to show basic catecholamine functions. So this is a extracellular fluid. This is inside the cell. Here's the lipid membrane. This is the receptor, alpha, beta receptor, whatever. So let's pretend this is a beta receptor, and I'm giving somebody epinephrine. So the stimulatory ligand would be epinephrine, and you attach it to the receptor here, and it causes an activation of G proteins in the membrane, which in turn activates the enzyme adenyl cyclase, shown here in red. And the adenyl cyclase causes the burning of ATP. ATP gets burned, used, and converted into cyclic AMP. With a release, this is adenosine triphosphate, this is adenosine monophosphate, Well, what happened to the two other phosphates? And the answer is they got released and used for energy. So you're releasing two high energy phosphates. So, the second messenger in sympathetic nerves is known as cyclic AMP. Cyclic AMP. That's the second message. The first message is the uppy attaching to the receptor. So the first message I'm giving to this cell is beta receptor has been stimulated. The second message that will relate to the inside of the cell is that release cyclic AMP. That's the second message. Cyclic AMP is called the second messenger. Now, the cyclic AMP, yeah, here's ATP being burned by amino cyclase into cyclic AMP. That's the second messenger. See that in the up here? The blue circle is adenyl cyclase, the enzyme. So that breaks down ATP, and up with cyclic AMP. You got a second messenger, and everything's all exciting. Now, to get rid of the cyclic AMP, you break it down with a series of enzymes called phosphodiesterase. So PDE, see this green box right here? PDE, that means phosphodiesterase, abbreviation. Phosphodiesterase enzymes are the enzymes that break down cyclic AMP. And they break it down into just AMP. We're showing that right here. So phosphodiesterase breaks down cyclic AMP into just AMP. And then it's inactivated. And the AMP is taken back up with kinase enzymes, high energy phosphates, and you make ATP again, and you're back to the circle. Now, if I inhibit the enzyme phosphodiesterase in that little green box, and I don't let the cell break down cyclic AMP, do you think that's going to be sympathomimetic or sympatholytic? Right. Cyclic AMP is the second messenger. It's telling the cell to stimulate. If you don't get rid of cyclic AMP, the cell just keeps stimulating. You have to turn it off in order to settle down. So, the blocking of the breakdown of cyclic AMP by blocking phosphodiesterase causes a sympathomimetic effect, because it allows the second messenger to exist for a longer period. What do you give Melanon for? Kick the heart. It's an inotrope, right? But its mechanism is different. It doesn't work on a receptor outside the surface of the cell. The drug has to go inside the cell, attach to phosphodiesterase, block it, and then cyclic AMP is accelerated or stays for a longer period of time. Then the cyclic AMP causes a bunch of changes inside the cell, and they're activated. The third messenger in the cell, what it eventually does, it causes the release of calcium. So calcium is actually, see it, they show it down here. Calcium is actually the third messenger in the cell. So the receptor is the first, stimulating the receptor is the first message. Releasing cyclic AMP is the second message. And ultimately it leads to an increase in calcium, which causes some phosphorylations, and that's the third message. Now look at the bottom of page 125. I typed this in here. In cholinergic nerves, it's the same setup, except for cyclic AMP, it's cyclic GMP, guanine monophosphate. So in cholinergic nerves, you have cyclic GMP, and adrenergic nerves, you have cyclic AMP. So look at my little bullets on 125. Phosphodiesterase inactivates cyclic AMP or cyclic GMP if it's a cholinergic nerve. There's 7 families of phosphodiesterase enzymes, PDE 1 through 7. PDE 1, 5, and 6 are selective for GMP, and PDE 3, 4, and 7 are selective for AMP, and PDE 2 is non-selective. It'll do both. So if you look up milrinone in a book, it's classified as a PDE 1 inhibitor. PDE inhibitor. Blocks the breakdown of cyclic AMP and causes a sympathomimetic reaction. Question?
If it's PDE1, would that be GMP though?
But it's PDE 1. No, it's not. PDE 3. Thanks. I misspoke. PDE 3 inhibitor. Sometimes if you are giving somebody dopamine, dobutamine, whatever, Levophed, you're all working in units. You notice that over time it's less effective, either because their disease is progressing, or very often it's because the drugs are getting down-regulated and they just don't work as well. But you can give milrinone and it still works. But that's because it isn't going to the receptor. So if the receptor down-regulates, it doesn't matter. It's going inside the cell, working in a different mechanism on the phosphodiesterase enzymes. So sometimes milrinone is used as a kind of a last resort when the other drugs are not effective anymore. Very popular group of drugs that have this mechanism, they're PDE3 inhibitors, and that's Viagra. And who's the one with the bathtubs? Cialis. I still don't know what that commercial means. Why are these man and woman sitting in a bathtub holding hands? It's two separate bathtubs. You think if you took Cialis, you'd want to go in her bathtub? I better stop and get in trouble. Anyway, that works by phosphodiesterase inhibition, by the way. All right, so that's the 10 mechanisms. And so let's go back to page 114. I'll go through one last time. You can, I'm sorry, 113, excuse me. Okay, number one, mechanism that an autonomic drug can affect the sympathetic parasympathetic balance. One, you can interfere with the synthesis of the transmitter. You can block the synthesis. If you do that, then there's going to be less transmitter. That's sympatholytic. Look on the last column. I always wrote it in there for you. Number two, that's with the metabolic transformation. In other words, make it a false transmitter. Give it the wrong thing to synthesize. And that's Autonomic, methyl-dopamine, and that's sympatholytic. Number three, block the release, block the reuptake of the neurotransmitter once it's been released, and that's cocaine, and that's sympathomimetic. Four, you can block the storage into the storage vesicles, and that's sympatholytic. Number five, you can cause release, indirect acting, and that for us will be ephedrine and ketamine. Number six, prevent the release of the transmitter, and that's clonidine or dexmedetomidine. Number seven, just mimic the transmitter, in other words, be a direct agonist. Number eight is be a blocker, direct antagonist. Number nine, inhibit the breakdown of the transmitter. On the parasympathetic side, that's an anticholinesterase. On the sympathetic side, that would be an MAO inhibitor or C1T inhibitor. Then finally, number 10, interfere with the second messenger system. Prevent the breakdown of the second messenger. That prolongs the sympathomimetic action. and that's milrinone PDE3 inhibitor. Okay. So hopefully that gives you a mental picture of the different mechanisms and how you can go about it. And as I try to point out again and again, all you really need to know when all the dust settles is sympathomimetic or sympatholytic. If it's sympathomimetic, then let's go to my table we did last week. That's page 127. Go to page 127. And if it's sympathomimetic, then you're going to know the actions in all these various organs. So let's review one last time before we take a break. All right, in the eye, a sympathetic response. Oh, forgot. I got a drawing of this. Turn to page 130. This is regulation of the pupil diameter, and my buddy Art Hubka sent this. He found it in a book somewhere and wrote this up. So what they're trying to show is how the pupils dilate or constrict. So on the top, it says the pictures on the left show a representation of the eye accommodating for distance. And we talked about last week that you've got to be able to have depth perception as well as your pupil dilating or constricting. That's how much light is going in. You need both of those combined to be able to see properly. So accommodating is for distance, and it's showing you on the top there how your eye accommodates. If you block the ability to accommodate for distance, the pharmacologic term for that is cycloplegia. C-Y-C-L-O, cycloplegia, P-L-E-G-I-A. So, let's look at A, where he is on the left-hand side there. When ciliary muscles relax, the fibers are tensed, the lens is pulled back elliptically, the eye's focus is on distant objects. Look at B. When the ciliary muscle contracts, it releases the tension on the fibers, the lens becomes more spherical, and the eye focus shifts to objects that are close. So accommodating occurs because you're changing the ciliary muscle in the eye to accommodate for distance, how far away. Okay? As far as pupil dilation, it's in the next little box there. High light levels, the pupil will constrict. That's called meiosis. When there's low light levels, the pupil will dilate. That's called mydriasis. And the muscle that does all that is the radial muscle in the eye. So the ciliary muscle controls distance, vision, and your radial muscle controls pupillary size. So let's see what Art wrote at the bottom here. Notice that the lens of the eye rounds up, reading on the bottom, or accommodates, as you try to look at something closer, like reading written words. That's so the image can be focused on the back of the eye and the retina. For distance vision, the lens must flatten so the image can be focused differently on the retina in a different way. Atropine not only causes mydriasis by blocking parasympathetic input to the circular muscles in the iris, but also paralyzes the ciliary muscle, produces cycloplegia, impairing the ability of the lens to change shape for near vision. All right, well, that's all fine and dandy. Let's get to the point. Here we go. If you want to dilate somebody's pupils, let's go back to the table. Page 127. Look under the eye. Page 127. The eye. Radial muscle, which controls pupillary dilation and constriction, right? If you stimulate the alpha receptors in the eye, the pupil dilates. It's called mydriasis. So alpha agonists cause mydriasis. Done. Period. You take neosynephrine eye drops, there are such a thing, you can go in the drugstore and buy them. You drip in somebody's eye, their eye dilates. The sphincter muscle causes miosis. It constricts the eye. And the ciliary muscle then works on a separate issue, and that's distance vision or accommodation. Relaxes for far vision, contracts for near vision, that's accommodation. The alpha agonists only cause mydriasis. Atropine and scopolamine, the two belladonna alkaloids, cause mydriasis also, but they also then block accommodation. So they block near and distance vision. So the difference between those two, I can dilate, I'm trying to be clear, and I'm not even convincing myself. I don't know why my brain's not working today. If you want to dilate somebody's pupil, you got two drugs you can do it with. Number one, you can give phenylephrine and cause mydriasis, and you're done. Or you can give atropine, eye drops, and that also causes mydriasis, but in addition, it causes cycloplegia. So you lose the ability to accommodate for distance. I mentioned last week, for those who wear glasses, or just about anybody who's been to the eye doctor and had an exam, they put atropine eye drops in, and they always want you to have something to drive you home, because you can't accommodate for distance. So alpha agonists cause mydriasis. Anticholinergics cause mydriasis also, but in addition, they cause cycloplegia. Right, is everybody with me on that? All right, the heart, we did, that was easy. By agreement, somebody sat down in a room and said, when you stimulate the heart, we'll call it a beta-1 receptor. So if you look, beta-1 causes everything to increase. Chronotropic, inotropic, dromotropic. Everything's faster. On the parasympathetic side, the vagal effect in the heart slows everything down. So that's easy. All right, let's take a break. Page 127. 127. Okay, back to blood vessels. We said that was the easy one because the alpha receptors constrict and the beta receptors dilate. That's entirely controlled by the sympathetic side. Your lungs, of course, beta-2 are the dilators. And cholinergic constricts. GI tract, sympathetics slow everything down, tighten up all your sphincters, and parasympathetics speed everything up. Now the kidney was an exception. I remember I mentioned last week, renin secretion from the kidney is a beta-1 effect. So even though I said beta-1 is always in the heart, this is an exception. Beta-1 is also in the kidneys. And you'll see when we talk about hypertension in a couple weeks and go through the antihypertensive drugs, one of the main reasons why beta blockers drop your blood pressure is because they block renin release from the kidneys. Okay, uterus, pregnant mom, beta receptors relax the uterus. And again, that's referred to as a tocolytic effect. And on the next page, 128, the islet cells in the pancreas release insulin. Sympathetic effect is to decrease insulin release, and that's to modify the amount of insulin that comes out. Because when your blood sugar goes up, insulin release goes up. So this is meant to temper that so it doesn't go too high. And then lipolysis or burning of fat is a beta 1, 2, and 3 effect. And that provides energy. So that's kind of the table we went through the last time. And the 10 mechanisms. Phew. That's a lot of talking. All right, then lastly, last week we finished up it's never a good idea for me to touch buttons. There's always a Clinton phone call at the end. All right, so I'm going to show you a couple examples. Let's go to page, oh no, I want to do the first. We went through that cardiac thing, so let's just mention that. Page 131. We finished off last week, and I'll go on the camera and point. Or not. There we go. We talked about the cardiac drugs and all the cardiac effects. Thank you. See me looking at it. And not to go through it in great detail again, but just to mention, since we're talking about the different receptors and the nuances of the different receptors, I wanted to use a class of drugs or a group of drugs you're familiar with, which you are eminently familiar with all these drugs, and said we have a pure alpha agonist like phenylephrine, you're going to get an increased systolic, diastolic, and SVR, and reflex bradycardia. The Levophed is primarily alpha with a little bit of beta, so you get an increase in heart rate from the beta, all the rest goes up. Epi, primarily beta with some alpha, similar thing, but because of the beta you can get a lower SVR if you give real low doses. Dobutamine is a pure beta, so increased systolic, decreased diastolic because of the vasodilation, and increase in heart rate. And then lastly, dopamine, and that's kind of where I left off. And if you want to go to the next page, I've got a little drawing in there. I'm sorry the lines came out a little faded. But this is a dose response curve. During the response, percent to 100%, versus increasing doses of dopamine. And you can see this first response curve here is the low dose, 2 to 5 mics per kilo per minute. And at low doses you get stimulation of dopamine receptors by themselves. So this is supposed to be dopamine receptors here. And if you give low doses of dopamine, get dopamine receptors, then the physiologic effects you get are dilation of the renal artery, so you get an increase in renal blood flow. You're hoping if the kidneys are working that more blood flow to the kidneys will mean an increase in GFR. That'll mean an increase in urine output. And you get a little bit more GI blood flow, which is, who cares? All right. If you give a higher dose, this is 5 to 10 mics per kilo per minute, then you start getting beta receptor stimulation, and that's shown here, that's beta receptors. And that means you kick the heart, which is usually why you're giving dopamine in the first place. Then finally, if you use high doses, 10 to 15 or 10 to 20 even, then you finally get alpha receptor stimulation. And because they're alpha receptors, and you always think of the word vasoconstriction when I say the word alpha, you get vasoconstriction. So no longer do you have an increase in renal blood flow, because the alpha constriction is more potent than dopamine dilation. You end up with vasoconstriction and stimulation of the heart. You usually don't want to go that high. Okay? Now, this next page, 133, this is a table from, I think, Cecil's medicine book. I'm sure I put the reference. Yeah, from Cecil's medicine. This is a textbook of internal medicine. That's the Bible of. You can see the last edition was the 25th edition. They've been writing this book a long time. I'm only on number 6. So I don't think I'll make it to 25. But they just talk about the pressors, and I put this table in here because, again, they kind of do the same thing I do. I use a little more crude thing with arrows up and down, but they're using numbers 1 plus, 2 plus, etc. And nonetheless, there's dopamine, and they're saying in a dose range of 1 to 4. My little fifth thing says 1 to 5. And vasculature and so on, renal doses is what you get. 5 to 10, you start to get beta. Then 11 to 20, you start to get the alpha. And the comment is the renal dose does not improve renal function, and it may be used with bradycardia and hypertension. So even though we thought improving renal blood flow would be helpful to the patient's outcome, it doesn't seem to work. There's vasopressin and phenylephrine. They're saying it's best for SVT. Yeah, that's because it causes reflex bradycardia. We don't use it too much for that. And there's norepi and epi. Dobutamine's on the next page. And then Milrinone. And its various uses as well. And as I mentioned the last time, the group of patients that always seem to be the hardest to deal with are septic shock patients. And they're mentioning either vasopressin, or if they're under norepinephrine, they say first-line vasopressor for septic shock or vasodilatory shock. So there's just some of the uses the current medicine books are saying. You've given these drugs enough to, you could fill this in yourself. Okay, I want to go to page 139. Page 139. Let's talk about vasopressors for a minute. And I want to mention, very easy thing to mention, that vasopressors are called that, pharmacologists call either drugs vasopressors versus inotropes. And their differentiation is vasopressors you give them in a syringe. Inotropes you give a drip. That's the difference. They all do the same thing. They're all either alpha or beta or dopamine agonists. So it doesn't mean that if I call something a vasopressor and I call dobutamine a drip, inotrope a drip, it still means the same thing. They're all getting alpha and beta receptors. So let's talk about ephedrine. Well, let's go through this table. This I took from somewhere, can't remember where, but they talk about number 1 on the top. Natural catecholamines, epi, norepi, and dopamine, and you notice they're saying epi is a little bit +1 alpha, +2 beta, direct acting. Norepinephrine is primarily alpha with a little bit of beta, and then dopamine is all 3, depending on the dose you get. Dobutamine under synthetic catecholamines, dobutamine is, of course, pure beta. So 0 for alpha. That's it. All right, so next one down, synthetic non-catecholamines indirect acting. But here comes ephedrine. Ephedrine is used way too much in anesthesia. We love it. We use a lot of it. Probably should use less. Just get more fluids and stuff, but that's personal opinion. Anyways, ephedrine is a little bit of a unique drug, and it is a very good drug. It isn't the ephedrine that I'm arguing against. It's using all the vasopressors. But the ephedrine mechanism is this. It has both peripheral and central action. So first of all, rarely do these catecholamines pass the blood-brain barrier. If you give a levophed drip, if you give an epinephrine drip or whatever, they work strictly from the neck down. They don't pass the blood-brain barrier. There are catecholamines in the brain, but you got to make them in the brain to get them in there. If you give a drug, it doesn't really have much effect, CNS-wise. That's why people who have Parkinson's take L-Dopa. They don't take, the problem is a deficiency of dopamine, but you can't give them dopamine because you can't pass the blood-brain barrier. So you have to give them a precursor, that'll pass, and then the brain converts it to dopamine. Okay? So ephedrine is both peripheral and central acting. It's one of the few adrenergics that can pass the blood-brain barrier. So you get both a central and a peripheral effect. And it's both alpha and beta stimulant. And lastly, it's both direct and indirect acting. So it goes directly to the alpha and beta receptors and stimulates them. It also has indirect action, that it causes catecholamine release. So there's 6 things to remember. When somebody says ephedrine, you just say this sentence to yourself. Peripheral and central, alpha and beta, direct and indirect. That's it. That's the mechanism of action of ephedrine. It's both central and peripheral acting. It works on the alpha and beta receptors. And it's both direct acting and indirect. So if you give somebody that's catecholamine depleted, let's say they've been in shock or they have problems and they're sick, they've depleted catecholamines, you still can get a decent effect because the direct acting will work. You won't be indirectly releasing catecholamines because they don't have them, but the direct actions will still work. So it gets, one of the mechanisms will work. That's the nice thing about ephedrine. It most always works. You have to vary the dose, but usually works pretty well. So let's look at page 139. Ephedrine. 2 plus alpha, 1 plus betas, indirect, some direct action. There you go. Just remember my 6 words. I'll say it one last time. Peripheral and central, alpha and beta, direct and indirect. That's how ephedrine works. Now you know. You go home from school happy today. My tuition's getting me some knowledge. All right, let's look at phenylephrine on the bottom. Phenylephrine, of course, is a synthetic drug, direct acting only, and you notice it's 3 plus alpha and nothing else. Pure alpha agonist. So phenylephrine is a direct acting, pure alpha agonist. Ephedrine is a direct and indirect acting alpha and beta agonist. Central and peripheral. And that's the difference. Now, and I'm not going to get into all this, but if you see patients on catecholamine-like drugs, they're on NMDA inhibitors, they're taking tricyclic antidepressants, they're taking SSRIs or SNRIs, whatever, some psychiatric drug. They always ask you, if the patient needs a vasopressor, which one do you give, ephedrine or phenylephrine? And the answer is always the direct-acting phenylephrine. So just remember that. You're going to get asked that sometime in your anesthesia career before you graduate. So if somebody's on an MAO inhibitors, they're depleting their catecholamines, and so the ephedrine won't work as well because the indirect action will be less. See what I mean? If they're taking some other psychiatric medicine, usually they work by depleting catecholamines somehow, make the patient less manic and so on. Then you want to get a direct action and get it to work. More predictable. Okay. Okay, now let's go to page . Oh. Go to page 126. Now I'll just mention a couple of ancillary drugs. You may know about them, but just to show you some mechanisms here. And the first one I put in here this is from May of 2017, and it's a new drug that was released to help combat the tardive dyskinesias from people who take Parkinson's drugs. And what happens is they can get spasms and all kinds of side effects from the Parkinson's drugs. As I mentioned here in the little write-up, page 126, tardive dyskinesia is a neuro disorder characterized by repetitive involuntary movements of the mouth, tongue, face, or extremities. It occurs with prolonged use of anti-dopamine drugs, especially first-generation antipsychotics, and Ritalin. So anyways, this drug they released to help minimize the side effects from their Parkinson's medicines. And if you look at the mechanism, the drug, Ingreza is the trade name, inhibits VMAT2. VMAT is the vesicular monoamine oxidase transport. That's the pump that pumps the catecholamines back into the nerve. That's pump number 1, VMAT1. And then from the cytoplasm into the package again, that's VMAT2. This blocks VMAT2. So what do you think happens to the catecholamines in the vesicle when you take this drug? They get broken down by MAM, right? Because they're in the cytoplasm and they're not protected. Let's read what they say. Valbenazine inhibits VMAT2, a transporter that regulates monoamine uptake from the neuronal cytoplasm into the synaptic vesicles for storage and release. Its mechanism of action in the treatment of tardive dyskinesia is unclear, but inhibition of the VMAT2 reduces synaptic monoamine levels. All right, the second drug there I have is tyrosine hydroxylase inhibitor. It's called Demzer, and that's mechanism number 1. Remember, mechanism number 1 is blocking the synthesis of catecholamines. And that's what Demzer does, metyrosine. It's the only tyrosine hydroxylase inhibitor on the market. It's responsible for catalyzing the conversion of tyrosine into dopamine, into dopamine and so on in the catecholamines. It's the rate limiting step. If you inhibit the enzyme, you get a decreased amount of catecholamines. This drug is used to treat patients with pheochromocytoma. So somebody's coming to surgery for a FEO, removal of the tumors that release catecholamines. Anybody taught you FEO yet? No? Okay. You'll get it eventually. Anesthesia for pheochromocytoma. That's a lot of fun because their blood pressure's all over the place. 300, 100, 250 every time you take it. So this is done to try to deplete catecholamines out of the tumors so that when the surgeon manipulates them, they don't release as much and cause hypertension. COMT inhibitor, that's mechanism number 9, is inhibition of the breakdown of the transmitter. And this drug, Tasmar, is recently released. My microphone just went out. For the treatment of Parkinson's disease as an adjunct to L-dopa. So if you inhibit COMT, what happens to your catecholamine levels? Up or down? Up. You'll have a better response to Parkinson's. So just to show you a couple of mechanisms that you can use to manipulate this up or down situation. Okay? Now on page 137, just going through some of this miscellaneous things. This is just a drawing I saw in a book somewhere. Get some better. Okay. Yeah, this just showing the sympathetic nerve function, and it was drawn a different way, so I thought it would be a nice way to repeat. So here's the sympathetic nerve. This is norepinephrine stored in the packages, synaptic vesicles. You release norepinephrine into the synaptic cleft. It attaches to an alpha receptor, produces vasoconstriction. Some of it feeds back on the alpha-2, and you get a negative feedback. So alpha-2 receptor mediated negative feedback. That's why they have the minus sign there. Clonidine and dexmedetomidine do the same thing. They're an agonist at alpha-2 presynaptics, and they decrease catecholamine release. So. Now finally, let's go to page 140, and just one last time, I mentioned, and there's the vasopressors. Either phenylephrine or ephedrine are the two that we use. This dosing and so on. And phenylephrine is pure alpha, and ephedrine is everything. Okay. Any questions about any of that? Good. Now, what I want to do is, let's just take an example of some autonomic type drugs that maybe you're familiar with. And so if you go to the next page, 141, I want to talk a little bit about asthma. And I only do this because well, it's an important disease process for us in anesthesia, Because anything that interrupts regular breathing, or any patient that comes to us with a respiratory issue, of course, it puts an extra burden on us and the patient, of course, for maintaining their airway, because they already have breathing problems, and we don't like people with breathing problems. We like the people, we don't like the disease. So somebody who comes to surgery with any kind of respiratory issues, of course, is always a challenge. But it's a nice representation of how some of these alpha, beta receptor drugs work and so on. So let's just go through this as an example. We're not going to cover it in great detail because that's not the point of this class. It's mostly to talk about drugs. But we can take a little side trip down memory lane and do some asthma pharmacology. So on page 141, just briefly, well, asthma in general, it actually is not a success story. In fact, the prevalence is getting worse, not better. And there are more episodes of people going to the hospital for asthma attacks. The frequency in children is going up. And so we're not really addressing it well. Most of the cardiac diseases are being addressed well and they're going down and so on, but this is an exception. So we're not very successful. And the drugs we have for it are marginally successful. Successful in some people, but not all. But anyway, they classify, this is classification of asthma, page 141, and it's classified into 4 steps. And with all disease classification, the beginning steps are more mild, and then the more steps you go, the more severe the disease gets. So step 1 is somebody who has mild intermittent asthma. Step 2 is somebody with mild persistent asthma. Step 3 is somebody with moderate persistent asthma. Then finally, step 4 is somebody who's very severely affected with persistent asthma. And there's some of the signs and symptoms, which I don't really have to worry about going over yet. But nonetheless, the asthma, like I said, with all the diseases we're going to go through, we're going to see that they go from mild to severe. Now, if you look on the next page, page 142, this is the World Health Organization, I believe. Their what's called stepped care approach to the treatment of asthma. And again, I'm not going to go through all this stuff, but just to mention, step 1 is the person with the least symptoms, the mildest form, and then as you progress up the steps, 2, 3, 4, 5, 6, patients are more severe, the drugs will get multiplied, how many they're on, the doses go higher, and when you get up to step 6, you have a pretty sick patient. So where I want to go is to the medical letter. So take a look at this page 144. And this is relatively recent. This is August of 2017, so it's just a few months ago. And they spend a lot of time in the medical letter talking about asthma. This is kind of the newsletter for all the medical world, drug world. And they spend a lot of time on asthma because it's a very difficult disease to treat. Success rate is pretty lousy. Anyways, let's take a look at some of this. I'm on page 144. The goal of asthma treatment is to control symptoms and prevent exacerbations, of course. The management of acute exacerbations of asthma are not discussed here, but I'll discuss them. Okay. So first and foremost, they right here, inhaled SABAs. SABA means short-acting bronchodilators. Short-acting beta agonists, I'm sorry. I'll be right. Short-acting beta agonists. Albuterol, salmeterol, you know, the usual. So first and foremost, if you're asthmatic in the United States and the world, because the World Health Organization says the same thing. If you're asthmatic, the number one thing, first of all, you get a prescription for a puffin, metered inhaler, short-acting beta agonist, SABA. The inhaled short-acting beta agonists, albuterol and levoalbuterol, are used for rapid relief of asthma symptoms. Their effect begins within 5 minutes, peaks in about an hour and a half to an hour, and should last 4 to 6 hours. They do not decrease airway inflammation and are only used to treat symptoms. So right off the bat, the prescribed treatment for acute wheezing, asthma attacks, bronchoconstriction is to take puffs of a beta agonist. Every asthmatic is going to have one, a puffer, a metered dose inhaler. We'll go through them a little bit, but not a lot. But basically, they're designed by the drug companies. The FDA asks them if they can make the dosing, because of course different drugs have different doses and so on. If they can make the dosing to come out to about 2 puffs. So if you don't know that particular metered inhaler, because there's a zillion of them on the market, everybody's got me too drugs, and you see a patient with it, and they want a dose, the dose is 2 puffs. I can tell you. Trust me, I don't even know what the drug is. I'll tell you, the dose is 2 puffs. So give them 2 puffs, pre-op holding or whatever. The people who take it for symptomatic relief, PRN relief, as they say, should be needed infrequently, less than 2 times a week. And of course, the beta agonists can cause tachycardia and tremors. When you get a lot of catecholamine release, your muscles start to quiver and you feel kind of weak. And tolerance can develop with regular use. So the less you use them, the more effective it is. Okay. Now, number 2, the short-acting muscarinic antagonist, SAMA. And there's one, it's called ipratropium, and it's an atropine analog. And remember, your bronchioles are controlled, beta-2 agonists dilate them, cholinergic or vagus constricts them. So if you give an anticholinergic, they cause dilation as well. But it's mild, it's much more mild than a beta agonist. Nonetheless, ipratropium is a SAMA and can be used as a bronchodilator. Okay, next page, 145. The next treatment is for somebody who doesn't get enough relief from the SABA, their puffer. Then they can start taking some medications, and the number 1 treatment, prevention treatment for asthma, is to take a steroid, inhaler. So inhaled corticosteroids on page 145, and that's the treatment for chronic therapy for asthma. So here's the question I'll ask you in the next test. You ready? It's easy. What's the therapy for an acute wheezing asthma attack? SABA, bronchodilator. What's the therapy for chronic asthma? The answer is an inhaled steroid, inhaled corticosteroid. Let's look what they say. An ICS, or inhaled corticosteroid, is the most effective long-term treatment for the control of persistent asthma of any severity. Most of the beneficial effects of the steroids are achieved at relatively low doses, fortunately. Patients should receive the lowest dose that maintains control. And this may change over time in the seasons. It's when the hay fever is out, they may need a little higher dose and so on, but it should be good. Current evidence suggests that at usual doses, all ICSs are similar in efficacy. They're not interchangeable, however, on a per microgram per inhalation basis because the dose varies with the drug. So, the best way to treat chronic asthma is inhaled steroid. The best way to treat acute asthma is a inhaled bronchodilator, beta-2 agonist. Okay? Now, adverse effects. Oh my God, we could talk about these for weeks. What are the adverse effects of steroids? In fact, what I did was look on page 143. Every drug book in the world has this in there. What are the side effects of taking chronic steroids? Everybody knows these. Going to any gym in LA and they're all taking chronic steroids. And they all got this problem. All right, so these are the common wisdom. You learn this in nursing school. All medical people know this. Acne, adrenal suppression if you've taken avascular necrosis, behavioral changes, roid rage, cushingoid changes, fluid electrolyte imbalance, hyperglycemia, peptic ulcers, and onward and outward. So needless to say, chronic steroid therapy is fraught with a number of side effects. It's only instituted as a method of last resort, so you have to be careful. Now, here's the beauty of it. Figure this one out. I don't know the answer. Now, we give drugs inhalation all the time, right? Sevo, Des, whatever. It's fast. It's efficient. Works great. You give these steroids inhalation, and they don't have any systemic effects. They just work in the lungs. Hey, that's pretty convenient, right? So all these side effects that we talk about with steroids almost never occur if someone just takes puffers, inhaled steroids. So by the inhalation route, you greatly minimize the side effects of steroids. In fact, if you see a patient coming to surgery with asthma, this is going to happen a lot because a lot of people have asthma, and you say, what medicines do you take? And they take an inhaled steroid. You don't have to worry about steroid suppression. You don't have to cover them with a steroid prep of any kind because they don't get that from the inhalation route. If they're taking them orally, then you got a different story. Okay? Go to the next page, 146. They're talking about the inhalation of steroids. They say clinically relevant adverse effects like HPA axis function and so do not occur with low or medium doses of ICS. So inhalation steroids don't produce all that suppression of the adrenal axis and all the rest of that stuff. Patients who require high ICS doses should be monitored for axis suppression, bone density, and so on. Okay. Now, the next treatment, and that's inhaled long-acting beta agonists. Well, naturally, you can imagine that if you're taking albuterol and it works 4 hours, wouldn't it be nice to take a puffer that lasts 24 hours? Then you wouldn't have any bronchoconstriction. That would be the logical drug thing to do. However, here's what happened. They developed some long-acting beta agonists. They're called LABAs instead of SAs. SA is short-acting, these are long-acting. But the patients who are taking them have a higher mortality and morbidity of their asthma than patients who take short-acting. So why is that? Don't know. Some people said, well, maybe because they're sicker, so it just looks like they're dying more or having more issues because they're sicker in the first place. Other people think it's the drug, something the drug's doing. Maybe it's causing downregulation, it's causing changes in the bronchi, who knows. However, they try to avoid taking these long actors unless they have to. Because one thing nobody argues with is that they increase morbidity and mortality versus a short-acting. So these are only reserved for people who have severe persistent asthma and that are on multiple drugs. So look what they say. The LABAs, especially if used in higher doses, can cause tremors, etc. An FDA analysis found use of the LABAs associated with an increased risk of asthma-related hospitalization, intubation, and death. That doesn't sound like a fun side effect, does it? Now, and they also make combinations, steroids and puffers together, and so you don't have to take 1 metered inhaler. They have every kind of combination known to man to make it easy for the patients and so on. So, all right, and then, I'm running out of time. Let's take a break. All right, let's start up again, page 145. 145. For recommendations for the treatment of asthma on the top of page 145, number 1 bullet, inhaled short-acting beta agonists, SABAs, are used for acute relief. Number 2, patients with persistent asthma should be treated with an inhalation steroid at low doses. For patients who remain symptomatic despite taking steroids and a good inhalation technique, the addition of an LABA is recommended. Patients who continue to have uncontrolled asthma may need to take higher doses of steroids. For patients with severe asthma that's unresponsive to high doses of steroids, the addition of an inhaled long-acting muscarinic antagonist like tiotropium can help. And finally, there's some other techniques. Make sure the patient's taking their inhaler right, they're not having other issues with allergens and so on. There's some monoclonal antibodies that you can take, and if you want to look at page, I'm not going to go through them, but if you look at page 151, there's immunotherapy nowadays, and select patients with allergic asthma and so on, you can give Xolair. It's an injection. You take it once or twice a month, and it works pretty well, but it's reserved for patients with severe asthma. It's about $1,000 a month for the drug, so it's pretty expensive. Okay, so that's kind of a general idea, but what I wanted to get to, of course, as always, is let's talk anesthesia. So go to page 155. What if you get a patient with asthma? You all will, quite often, unfortunately, have asthmatic patients, so how do you handle it? What about anesthesia? So, I wrote an article once, years ago, with Mary Carlette, and published it in the ANA Journal. And this is where this comes from. Now, it was about 10 years ago, so the drugs have changed, and we had to update it. Mary's stuff stayed the same, physiology doesn't change. But we did update it. But that's where this is from. So Mary Carlette and I wrote this little thing. But what do you do? Well, first of all, several important anesthetic, I'm on page 155. Several important anesthetic considerations have been discussed. Pre-op considerations and strategies. Well, of course, we have to put this in here so we don't get thrown in jail. But a careful pre-op history and physical are essential to discern the current disease status and medication profile. So in other words, find out what the drugs the patient's on, How are they? Listen to their chest. Are they wheezing? How often do they have symptoms? Is it daily? Is it weekly? Is it, occasionally? How do they get rid of their symptoms? Do they take an albuterol inhaler, or are they on steroids or whatever? Should you do pulmonary function testing? The answer is probably no. It doesn't tell you anything you already didn't know. They got asthma. It doesn't really help stratify them in the beginning. So the second paragraph there, predictive value of routine pulmonary function testing, remains controversial because you already know they have asthma. What are they going to find out? Still going to do the same thing. If you haven't noticed yet, we find all these things out, and then we give propofol, SIBO, Baccaronia, and that's it. So, I didn't say that. Number 3 paragraph. Pretreatment with systemic corticosteroids has been advocated for patients with asthma who are undergoing surgical procedures. Now, what I didn't say, and I was just assuming you knew this, and I think you do, is that if somebody is going for elective surgery and they show up in the pre-op area and they're wheezing and they have symptoms, you don't do the case. I mean, you just don't do elective surgery and somebody's having active respiratory symptoms. So it's only going to have to deal with that when you're doing somebody on an emergency basis where they require surgery, they have to have it, and they're wheezing, and then of course you have to put it on all stops. But in a routine case, you can just send them back to their doctor and get them tuned up a little bit, and they can come back at a later date for their elective procedure. However, if you can't, you have to do the case, and the patient's having some symptoms and so on. The third paragraph, they've done studies looking at, well, what if we give them IV steroids? Is that helpful, or isn't it? And they talked about the steroids here. They had a study of 89 patients. 86 had wheezing when either given prednisone or hydrocortisone preoperatively. Complications of the steroid therapy, such as delayed wound healing, infection, and adrenocortical insufficiency, were not noted. So they gave one dose. Like we give Decadron for antiemetic, one dose. They gave one dose of hydrocortisone or one dose of prednisone just to get them through the induction in the case. And that seemed to be effective, and there was no side effects to it. So that's one possibility. If you're doing a patient, they're wheezing, pre-op holding, they're taking inhalation steroids that are obviously having breakthrough bronchoconstriction, then go ahead and give them Decadron. Why not? You got to give an antiemetic anyway, so you might as well do that and see if you can kind of get at both things. Fourth paragraph, routine pre-op meds should be given to allay anxiety. Anticholinergics such as atropine and Robenol exhibit mild bronchodilating effects, and so they could be a possibility to try some Robenol if they're wheezing. Caution must be exercised when administering narcotics to patients who are having respiratory difficulty. Hello, you should know that, right? If they're having problems breathing, you don't want to be giving them fentanyl. Awake, anyway, you can do it on the sleep. Caution must be when administering narcotics, and you don't want to use the narcotics that cause histamine release, which are, thank you, very good, morphine, Demerol, codeine, and the phenanthrine drugs, right? Plus Demerol. So yes, you're correct, thanks. Fentanyl and our drugs are not histamine releases, so they're safe. So all the phenylpyperidines are safe. Now, here's a biggie. The use of H2 receptor blocking agents, such as cimetidine, ranitidine, famotidine, or nizatidine, is contraindicated. Here's why. Follow me on this. You already know this. You give somebody an H2 blocker, what happens? Well, I'm going to show you. I got a little picture here. What I got here. And we just looked at it. Here it is. I'll go in the camera. Back to this picture. If you give somebody an H2 blocker, so I take Zantac or Tagamet or whatever. And a lot of people do because it's over the counter in the drugstore, so they can take it at will. Well, you're blocking this alpha-2 presynaptic receptor. You're blocking the postsynaptic receptor. To say this is a histamine receptor, H1. You're giving them an antihistamine. So let's say it's an H2 receptor, and there would be an autoreceptor H2. You give Zantac, you block that. This is negative feedback, right? You block the negative feedback. What happens to histamine release? Up or down? Goes up, because you're removing the negative feedback. So you give somebody Zantac, and you're increasing the amount of histamines being released. Right? Now, the H2 receptors, doesn't matter. They're blocked. But the H1 receptors are not blocked. Because histamines are specific for receptors. You have H1 blockers, which is, what's the H1 blocker? Benadryl, thank you. The H2 blockers, and they don't cross over. So you still have H1 receptors that aren't blocked, and now you cause histamine release by giving that Zantac. So you're going to potentially make the patient worse. So if you're giving somebody an H2 blocker, say, and people like to do that for GI reasons, and, to help them with possible aspiration or whatever crazy thing they think of, then you can't give it to asthmatics. So when they say H2 blockers are contraindicated in asthmatics, that's why. Does that make sense? I'll say it again. If you give us an H2 blocker, like Tagamet or Zantac, whatever, it's going to block H2 receptors. Okay, that's a given. But it also blocks presynaptic H2 receptors, the autoreceptors, inhibits the negative feedback, and promotes histamine release. So yes, you're blocking H2 receptors, but you're promoting histamine release, and the H1 receptors have not been blocked. So you can get side effects. Yes?
You get Benadryl with it?
Then you fix it, yep. If you give Benadryl and give an H1 blocker too, then take care of it. But you got to give two separate drugs. So, back to my thing on page 155. The use of H2 receptor blocking agents should be avoided. Bronchospasm following their use has been reported because of the loss of inhibitory feedback control via presynaptic H2 autoreceptor blockade. It results in histamine release. Okay, does that make sense? So I'm trying to get you into this idea of receptors, presynaptic, postsynaptic, whatever. Okay, down the bottom of page 155, interoperative consideration and strategies despite a definitive controlled trial. Regional anesthesia is generally considered by anybody in anesthesia as safer than putting someone to sleep. So if you can do a block, do a block. I think everybody would agree with that, even though there haven't been great studies. Finally, the last paragraph, of all the common induction drugs, propofol, etomidate, and ketamine have all been used successfully. However, if the patients have an active wheezing, they're going to have this emergency procedure, then the drug of choice, the only bronchodilating induction drug is, thank you, ketamine. If the patient is not wheezing, if they just have a history of asthma, then you can use propofol. Propofol is perfectly fine. It doesn't release histamine, it gets them nice and deep fast. That's a good thing. So propofol is fine, but if they're wheezing, then ketamine's better for induction. All right? Now, as far as next page, 156, in patients where they need a relaxation, what relaxants would you use, what would you not use? This is simple. You don't want to use any histamine releasing relaxants. And the histamine-releasing relaxants are succinylcholine, could be one, yeah. Atracurium, mivacurium, there you go. Okay. The potent on the second paragraph on page 156. Of course, the inhalation anesthetics produce bronchodilation, so that's good. Use SIVO. DES, unfortunately, causes respiratory irritation, so it would not be your drug of choice. If you're going to give somebody something, give them SIVO. Well, that's not hard to figure out, right? Give them SIVO anyway. Other anesthesia-related medications that should be avoided in a patient with asthma are the histamine-releasing relaxants and the beta blockers. So esmolol and labetalol, if they have difficulties with blood pressure or heart rate, we're going to talk about that in great detail, but if they do have, you don't want to give beta blockers to an asthmatic because beta blockers cause bronchoconstriction, right? Your lungs are controlled by beta-2 receptors. That's why you give albuterol, beta agonist. So a beta blocker is going to cause bronchoconstriction, not bronchodilation. If you look at a package insert for any beta blocker, they always list, number one, 3 contraindications, 3 patient populations. We're going to get into this next week. I'll give you a preview. 3 patient populations, they always say, be careful giving them beta blockers. Number 1 are asthmatics. Number 2 are diabetics. Because if you have diabetes, you take a beta blocker, it causes hypoglycemia. Because remember, the release of sugar from your liver and lipolysis are beta adrenergic functions. If you give a beta blocker, they tend to produce hypoglycemia. And to make it worse, one of the symptoms of hypoglycemia you look for is tachycardia. And if you give somebody a beta blocker, they're not going to get tachycardic. So not only have you made them hypoglycemic, but you made it harder to figure out that they're hypoglycemic by blocking some of the symptoms. And the last group of patients are patients with peripheral vascular disease, claudication. It's not a big issue for us in anesthesia. Our patients aren't walking around the OR, but if patients trying to have a life and walk around, they have peripheral vascular disease and they take beta blockers, they can have vasoconstriction of their vessels. Remember, alpha constricts, beta dilates. If you give a beta blocker, they vasoconstrict. Somebody with bad veins in their legs, it's going to cause vasoconstriction. That's not good. Okay. And finally here, ketorolac and other non-steroidal anti-inflammatories should be avoided in patients with aspirin-intolerant asthma. And as I think I mentioned before, when we talked about these last semester, there is a disease, specific disease called aspirin-intolerant asthma. These patients, if they take aspirin, they have an allergic reaction and they get an asthma attack. Non-steroidals too. So, acetaminophen and ibuprofen, etc. So they can't take those drugs. It's a small subset of asthmatics, but they know, they'll tell you, I'm aspirin-insensitive asthma. They know they have the disease. So it's not a big mystery. Okay, if an episode of bronchospasm occurs during anesthesia, I'm guessing somebody probably taught you this, but I'll say it again. The following steps are recommended. Number 1, get the patient deeper. The patient almost always bronchoconstricts during general anesthesia if they're too light. If you get them deeper, then they tend to be bronchodilated. That's just a generic statement. So, since you want to get the patient deeper, what can you do? Well, you can turn the SIVO higher. So with a volatile agent, you could give some IV ketamine. That would be a good idea. You could give them some propofol, put them down real fast. Give them 100 of propofol, so knock them down a little bit. give them some IV lidocaine, or any combination of those together. Just get the patient deeper. Anybody in anesthesia knows what that means. Then very often their wheezing will go away. Administer 100% oxygen. Number 3, give a beta-2 agonist. So give them albuterol, puffs. If you go into many patients in many sites, when they're seen pre-op, they're told to bring their inhaler with them to surgery. Not all, but certainly most people do that. And so when the patient and see them in pre-op holding, if they have their inhaler with them, give them a couple of puffs. It's not going to hurt. So that would be the first thing I do before you even got them back in the room. If you got them under anesthesia and you think they're having a bronchospasm and you're having difficulty ventilating, and they're taking high pressures and you can't squeeze the bag well, and you know all the signs of bronchoconstriction, then you can just puff some of the inhalation albuterol down their tube. And they say that it can take up to 8 to 10 puffs to get enough in, because it's going to stick to the side wall of the trachea tube plastic, and it's not going to diffuse in there well when they're asleep. So disconnect their endotracheal tube from the circuit, puff about 7 or 8 puffs down that tube, put the circuit back on and squeeze it back as hard as you can. Blow it all in there. And that will be a treatment. In severe cases, you can give epi-IV or sub-Q, administer IV steroids if that patient's still wheezing. And if long-term post-op mechanical ventilation is planned, you can consider aminophylline. Nobody does. So that's kind of managing them in-drop. As far as emergence, here's the question. This is the big question when you have an asthmatic. When do I take the tube out? Here's your dilemma. All right? Number 1, if you take the tube out, the sooner you take the tube out, the less, because the patient's waking up at the end, of course, the sooner you can get the tube out, the less that's going to be a stimulus in their now coming back airway reflexes. And so they're not going to spasm because the tube's in there and they're coughing and they're hacking and, you know, all that nastiness. That's the good news. So the sooner you can get the patient extubated, the better. The problem is, this patient has asthma, they're not breathing right, and you just pulled the tube out. Well, what'd you do that for? You just got rid of your secure airway. So maybe you should leave the tube in longer instead of shorter. You see, that's your dilemma. When do I take out the tube? The sooner the better. I think everybody would agree with that, because then they'll have less reactivity to the tube. But you want to leave it in long enough to make sure that when you do take it out, you're not going to have to be putting it back in again or some nasty stuff, right? So it's a judgment call. I don't know the right answer. Every patient's different. Let's read. I wrote this little part here. The primary issue during emergence is when to extubate. Some authors suggested deep extubation to avoid the mechanical stimulation from the endotracheal tube when the patient wakes up. And then that works. That's a decent thing. Others fear the loss of a secure airway before the patient awakening may present greater difficulty than the presence of an endotracheal tube. Well, one thing you know right off the bat is you put the tube in at the beginning of the case, you know how easy they were to intubate. If somebody's a routine airway and you intubated them in 10 seconds and there was no problem, then I'm a little more prone to getting the tube out earlier, because at least I know I can get the tube back in, because I did it an hour ago, an hour and a half ago. If somebody's a difficult airway and they're obese and they got a big neck and whatever all the signs of difficult airway are, then I'm having the cashier pull it out when they get discharged and they pay their bill. Oh yeah, before you go home, let me take that tube out of your mouth. So, you got to kind of have a judgment call. When do you think you can yank the tube out? And if you're comfortable that you could re-intubate, and you already know that because you intubated, then don't be so afraid to take it out. Otherwise, nobody dies from having an endotracheal in too long. I've never heard that, ever. So when in doubt, leave it in. you know, you want to make a mistake, make it on the safe side. That's always a good idea. Either way, a judgment must be made about when to extubate the patient, with the understanding that the earliest possible time is advantageous to prevent mechanical bronchial stimulation. The administration of IV lidocaine or small, non-respiratory depressing doses of opiates can help diminish respiratory sensitivity. So giving a little touch, 25 mics of fentanyl, sometimes can help to suppress his cough, as we know, the opiates do. You can give him some IV lidocaine right before you extubate him, 20, 40 milligrams. It helps their airway from being as irritated. So that's that. Now, second last paragraph is using anticholinergics. If you're using anticholinesterases, in other words, neostigmine, remember that neostigmine is a bronchoconstrictor. So some people recommend that you give a little extra Robenal with it, just to make sure you're not going to get bronchoconstriction. Who's Caroline? So, or just give them some Sugammadex. That'll be easy. Asthma in a pregnant surgical patient. Treatment for a pregnant patient with asthma is the same for non-pregnant patients. All the same drugs can be given. You might want to minimize the beta agonists if possible, because beta agonists do relax the uterus. We have messing with your own too. Okay, let's go to page 158. And since we're talking about histamine release and asthma and all that, I thought I'd throw this in here. And this is a little bit about allergic reactions to the anesthetics. On the top of page 158 is a table. This comes from the French study, which is probably on the previous page. Yes, it is. Mertes, that's the reference. It's on page 157. But this, the French do the definitive study for allergy to anesthetics. And they've been doing it for 40 years. Everybody uses their data. Because they track every anesthetic that's done in the country. And as they say in the reference, this is their latest national survey or something in this box. And the overall estimated number of cases of allergic reaction they're mentioning, and whether male, female, and overall. Neuromuscular blocking drugs were the number one reason for an allergic reaction to a drug under anesthesia. And you can see that 458 cases happened in an 8-year period. The second most common was latex, and I would say that's probably dropped off quite a bit because we don't really use latex anymore. Almost everything is latex free in the OR now, but at least the last decade it was fairly high. Antibiotics are next. I think they're probably second nowadays. And then other agents are just, well, other agents, radiopaque dyes, and things like that. So it's not common, but certainly if you do have an allergic reaction, it's almost always to the muscle relaxant during induction. Or Sugammadex can do it. That's when you're waking the patient up. If the patient does have an allergic reaction and they get a bronchospasm, there's the treatment. I don't have to beat it to death. I already went through it once. I put it again there on the bottom of page 158. Now, on the next page, this is a little table that I saw in an article one time. And fortunately, didn't get the reference. I apologize, but I like the way this guy did it. Because he said, because this is what happens. When you give anesthesia enough, you'll see it. Oftentimes, when you get a bronchospasm, it's right after intubation. You put the tube in, you hook up the circuit, you start to ventilate, and it's hard to ventilate. So you wonder, Is the patient having an allergic reaction? Or are they just a little light? You know, maybe I struggled a little bit longer than I thought when I put the tube in. And when you're struggling and you're putting the tube in, you don't notice the time. Right? Somebody standing next to you notices it's been 5 minutes, get out of the way, whatever. But it can, you know, it can be a longer time than you thought. Time warp, and so on. So he has this little thing in here. He goes, well, what if you put the tube in and the patient's tight when you first intubate him? What do you think it is? Well, this is what he says. Time onset of bronchospasm. Was it before they got intubated or after? Pathophysiological mechanisms. If it's before, when they got the drugs but you haven't put the tube in yet, that's what he's saying, then it might be more likely to be an allergic reaction than if it happened after you intubated. Do you have cardiac features? Yes. Tachycardia, hypotension, etc. As far as non-allergic bronchospasm, usually you don't get any cardiac changes. It's just a respiratory thing. So if present, delay, they're delayed. And do you get a rash, cutaneous features rash? Allergy, yes. Bronchospasm, no. So when you put the tube in and you start to ventilate, if the patient's tight, you're saying, is this an allergic reaction to something, or are they just light? Chances are, if they're not having cardiac changes and they don't have a rash, then they're probably light. Pump up the sebum. Give them some propofol, do something to get them deeper. Otherwise, if they have a rash and cardiac signs and so on, you might be looking at an allergic response. So keep an eye out for that. Now, on the next page, again, this is just a drawing I saw in some article, but I was impressed that this was a woman who wrote this fact. Went through all this trouble to draw this all out. I was kind of amazed. Schematic diagram of airway irritant reflex-induced bronchoconstriction by tracheal intubation. You put a tube in, the patient gets light, stimulated from the tube, and they get a bronchospasm. This is the circuit and why they do it. Aren't you glad you know that now? I'm never going to ask you this in a million years. I just thought I was amazed that somebody actually figured this out. Okay. Any questions on any of that? All right, let's quit for today. I don't want to get into the next thing. I need more time. So I'll see you next Tuesday. Thank you.